Welcome everyone. Thank you for joining with us for today's webinar. I am Sonia Das, Event Coordinator with Busy Events Management, MedTalk team, your host for today's session. On behalf of our MedTalk team, I warmly welcome our esteemed moderator and esteemed panelist members. Thank you for taking time out from your busy schedule and joining with us today for a panel discussion on primary care, the challenges and solutions. Welcome everyone. In order to make the session more interactive and to discuss on the queries related to discussion, the Q&A tab is available. Please type your queries or any discussion points into the Q&A tab in your Zoom control panel at the bottom of your screen. It will surely be addressed. Now, without further ado, let me introduce our esteemed moderator, Mr. Vikas Katoch, Chief Operating Officer, Right Health Holdings. Mr. Vikas Katoch is the Chief Operating Officer at Right Health Holdings, UAE's largest and fastest primary healthcare, having 58 facilities across UAE. Mr. Vikas brings with him 15 plus years of healthcare comprehensive experience, including regional experience in managing the business and operations, strategy, business transformation and optimization, complex P&L management, legal and statutory compliance, banking and funding, merger and acquisitions, board governance, project management, financial planning and analysis. He was the former finance director at Foundation Holdings, investment company in Dubai, was responsible for the F&E functions of Foundation Holdings and for finance, revenue, cycle management, and IT department for its healthcare portfolio companies in UAE. He was integrally involved in driving the business growth. Welcome, sir.
Thanks, Sonia.
And let me first introduce our panelist, Dr. T. Ahmed, founder and chairman of Al Noor Polyclinics. Dr. Ahmed finished his MBBS from Calicut Medical College and MS Ophthalmology from Kasturba Medical College. Dr. T. Ahmed is active in private healthcare sector for the last 40 years, in Dubai for 30 years. Dr. T. Ahmed was the Group Medical Director of GHI, Gulf Healthcare International. He is active in Social Life Director of Media One Channel. Welcome, Dr. Ahmed.
Thank you. Thank you.
Next, I would like to introduce Dr. C.I. Joseph, Pediatrician and Managing Director of Jupiter Healthcare Group. Dr. Joseph is a pediatrician and owner of Jupiter Healthcare Group, which includes all the Jupiter clinics and Mankul pharmacies. He embarked on his career in 1983 when he came to Sharjah and started his own clinic, Marina Medical Center. In 1986, he joined Dr. Joseph's Polyclinic at Karama. After that, he joined Joseph's Fizay's Polyclinic and opened another 3 polyclinics at Jebel Ali, Al Nada, and at Karama Metro Station. He started and sold the very successful Dr. Joseph's group of polyclinics and pharmacies earlier. His 43-year-old honed expertise lies in his management skills and vision to run affordable medical facilities. Welcome, Dr. Joseph. Next, I would like to introduce Dr. Mohammed Qasim Paliyatarite, Chairman and Pediatrician, Doc Al Shifa Group. Dr. Mohammed Qasim was the Chairman of Hotel South Regency and Rauda Healthcare Limited. He was the Chairman of Najurashad Islamic College and Global Public School. He is the Founder President of Puram, Forum of Trishur Expatriates in UAE, and Founder President of Kairali, a forum of expatriate care light in Jeddah, and founder member of AGES, a philanthropic organization in Jeddah, and president of Dubai Chapter, Association of Kerala Medical Graduates, AKMG, Dubai, in the year 2007 to 2009. Welcome, Dr. Mohammed.
Thank you, Sonia.
Next, I would like to introduce Dr. Ranjit Kumar Vijayan, CEO and Managing Director, Imara Healthcare, Clinic Care Medical Center. Dr. Ranjit Kumar Vijayan is a specialist general and laparoscopic surgeon. He is the CEO and Managing Director of Imara Healthcare. He graduated from Ramachandra Medical College, MS General Surgery from KMC Mangalore. He is also a fellow of American College of Surgeons. Welcome, sir.
Thank you very much.
And now I would request our moderator to kindly take over the session from here, sir. Over to you.
Thanks, Sonia. Thank you very much. Thank you for the warm welcome and the introduction of myself and all the esteemed panelists. Now I'm delighted to host this afternoon with all the senior veteran leaders who are there from almost, I believe, decades. including Dr. Kasim, Dr. Ahmed, including Dr. Joseph, now Dr. Ranjit also running his own practice, and then managing the shows. Now, before we kick off this session, let me just touch base the section which we'll cover today. So today webinar will run for 90 minutes or so, and we will cover basically three sections. First will be primary healthcare and its pains, areas, and the challenges. Then followed by proposed solutions by all the veteran leaders, and then Q&A session at the end, or we will discuss as and when it comes and been proposed by the public. I'll try to capture some of the questions which I can, considering the time allow us. Now, since this is all about primary healthcare and its current challenges, solutions, how it works, what are the things which people see, or what are the things which leaders see, that we are going to discuss. And since for the public, which are from healthcare or non-healthcare, primary healthcare basically is the most important healthcare system across the world. And why it's important, why primary healthcare is called primary healthcare. In a simple word, primary healthcare means right care at right time at right place, and that's why it's called the first doorstep of the healthcare system anywhere in this country or any other country across the world, wherein as a simple patient can step in and can avail the services, can see the doctor, can get himself or herself checked, and can make sure that he gets the right quality of service at his doorstep or in the convenience area wherein he stays in. So it's all about convenience, right care, right place, right time, so that all the public or the patients are taken care of. Now coming to the primary healthcare in UAE, which is our topic. So basically what I see before I hand it over to our esteemed panelists, I see there are some of the challenges which nevertheless is there for any country, right? And this country and healthcare in this country is not very matured, maybe 50 years old, unlike other country wherein it is has gone beyond 100 years, 150 years. So yes, there are some challenges, there are some solutions which as a leader, as a panelist, which we will be discussing in terms of questions, and then we'll be taking all the questions to Dr. Ahmed, Dr. Joseph, Dr. Ranjit, and many other questions coming to us. Now, what are those challenges? Though I'll be asking the direct question to the esteemed panelist. So basically, we will be discussing how it has shaped up or how it has evolved from last 20 years or 30 years, from a healthcare system which was a cash paying system to an insurance system, plus going and touching up the base that why the access to quality care is important, why there is overutilization by some of the providers, why it's not by many others, and what are the payment cycles, what are the problems by the providers, what are the problems patients are facing, and eventually the providers, payer, and the whole ecosystem is getting touch base somehow. And coming to the solutions, I will discuss with our panelists that what are the discussions or what are the solutions we see, can be proposed to the public, to the patients, to the providers, to the government, to the DHA, so that we, work together and then try to come up with the solutions which are currently needed in this primary healthcare. Now, those solution can be starting from, increasing the limit of basic plan, which I believe I hear the questions every time by everyone, or is there a need of more and more technology in this system? Like we see now, tele health is coming into picture, like we see some sort of robotic automation coming into picture, like we see the need of the clinical protocol by all the DHA or the authorities are required, or is there a need of more cohesive payer and provider relations, and so on. So that I will leave it to our senior panelists also. And I would like to thank everyone to come on this platform to discuss their own views, what they have seen, what they see, what they foresee, so that at least we have a fruitful discussion, and then we take some outcome out of this meeting to take it forward. And as a leader, I believe this is our responsibility to, cater all the questions and then propose the solution to the market, to the provider, to the peer, to the, corporate, so that all becomes a part of that ecosystem. And then somehow system is getting mature day by day. And though we are fortunate enough in this country to have this balanced ecosystem of healthcare, wherein all the services can be availed by everyone. So it's not for few, it's for, one for all, which means it's not for OPD, it's for IPD. It's not for one category of services, it's for all. So, thanks to the government who has done all this tremendous work in the last few years to make this system up and running, and a collaborative system wherein, everyone have the right to participate, and, all are welcome with DHA to take it forward. Now, moving on to the questions. Now let me start this questionnaire sections of this webinar by my opening question to Dr. Ahmed. Dr. Ahmed, so my first question to you is that how do you see the primary healthcare system has evolved in last 3 decades, since you are there from last 30 years, maybe more in overall healthcare? That's number one. Second, how do you see that cash paying healthcare practice has moved to mandatory insurance healthcare back in 16 onwards? So what do you see and what are your views? If you can please share with all the panelists and then the viewers.
Thank you, Vikas. It is my pleasure to join you in this session. Dubai is a fairy city, the dream city for people all over the world. We have got a cosmopolitan population in Dubai, but the evolution of healthcare in private healthcare in UAE and especially in Dubai, it is, as you suggested in your talk, is only a short history. See, when we look back to the early 90s, or when I came here, healthcare system was very primitive, I will say. It was very similar to the healthcare system prevailed some maybe 75 years or 60 years back home in our place. So the private healthcare system was controlled by, at that time, Department of Health, staffed with a single director, his personal assistant, and one staff in a 10 into 12 room. From that, this health system has developed in 30 years to what is at present, with huge department, with this renamed as Dubai Health Authority, with all subspecialties and categories to control private healthcare system. And we had to see that at that time in Dubai, we had less than 100 clinics and 1.5 hospital, I will say, because one hospital was Iranian hospital, at a daycare hospital. It was Al Dawali at that time. Nothing was there in private sector at that time. From that, it has the tremendous growth has happened here, along with the population of Dubai. Population of your time was less than 2.5 million, and Dubai population was 0.5 million, 500,000 only. And from there, the UAE population has reached almost 10 million, nearing 10 million this year, and Dubai population 2.8 million. This much as growth has happened in the population, and the peculiarity of this place is that this cosmopolitan population is staying here. No barrier of country or religion or anything like that. People from all over the world are joining here. So problems and requirements will be quite variable depending upon the places where they come here. So from that stage, Dubai healthcare system, private healthcare system has reached the present stage. So things were okay. After the second Gulf War, there are a lot of factors which led to the gross expansion of healthcare in Dubai or UAE, because post second Gulf War, economic boom attracted people to this place, especially doctors, where conditions or services were not that, living conditions were not that good as it was in Dubai at that time. So it attracted doctors. And there was one more thing I would say, a false perception of the profitability of healthcare attracted a lot of people, because when you look from outside, it was very charming and attractive. So that also attracted a lot of people, both entrepreneurs as well as corporates. They came here, and it was okay till some time because we had our 95 to 98% cash flow from the cash patients. Very few people had insurance coverage at that time. Then after coming up of a development of this Dubai Health Authority with great intention, and as a global requirement, they introduced this mandatory healthcare system. That was one of the best thing we can see about Dubai Health Authority, because that is an international requirement to have a affordable quality healthcare. I remember in those days in 95 when I started new clinic, I put this logo on my brochure. I still remember that: quality healthcare at affordable price. Till that time, I never seen that logo here in any side in private healthcare in Dubai, in this area. So with that aim only, DHA has introduced this mandatory healthcare system, which was meant for economically backward or not well placed working class people and with low income people. This is what I see. This is how this healthcare system has developed in Dubai.
Got it. Thank you, doctor. Thanks for all
Okay.
the words of wisdom you have shared, for all the experience which you have now. Obviously, yes, the system has evolved from many more angles, and obviously it has improved a lot versus earlier it used to be. Now, taking your points and then speaking to now Dr. Kasim. Dr. Kasim, now we have discussed what is primary healthcare, why is important, how it has moved. If you can share some light or shed some light on what do you see the current challenges in the current primary healthcare. Let's say take it from do you see the need of low network only for underprivileged labor community, or do you believe it should be for all? Do you see more and more affordable class nowadays moving to this low end plan is creating more burden on the system, on the healthcare, specifically after COVID-19, wherein the pressure has become more and more on provider as well as payers? So if you can share your views on this, Dr. Kasim, please.
Thank you, Mr. Vikas. Good afternoon and greetings to everyone from Dubai. I take this opportunity to thank MedTalk as well as the again, Mr. Vikas, for conducting such a valuable subject at this very difficult time of pandemic. Compulsory comprehensive insurance was introduced in Dubai with a very good intention that it will give affordable quality healthcare to every resident of Dubai. With the Dubai Health Authority, with a wonderful infrastructure here, a very good doctor-patient ratio, and a very high quality and supervision level at the authority, it was very much possible, and the intention was very good, and it is very clear. Only one thing, the premium offered was probably much well below the international level. That was the only thing, but otherwise, it was done with all good intention. And the low-cost network was introduced. Again, thinking that this will give affordable healthcare to the lower income group, the workers, the blue collars, and they think that this is possible with the healthy age of these workers. Probably it was manageable. Probably. Unfortunately, now everyone is coming to this network, the low-cost network, in spite of their position, in spite of their financial income. Even multinational companies, which used to provide very good healthcare policies to their workers, have now moved into the low-cost network. This has definitely produced some difficulties, and it has become, the policies have become unviable at this premium. And certainly, this has produced delayed and rejected payments to the healthcare provider. All the more, the strict approval regime and conditions posed by the insurance companies to restrict the melting of the low-cost premiums. They have created it hurdles of getting approvals easy and restricting the access to the specialist and even restricting the medicine because they cannot afford it. So this has produced tremendous inconvenience to the patients. And I think the very intention of doing the insurance with very good intention of giving good coverage affordable is probably not happening. As well, some of the things always, there will be a small element of mismanagement. So the closed network, so-called closed network, where the some of the company patients can only go to some facilities only, and also that the so-called capitation mode practiced by some of the TPAs, also creating that some facilities are very busy, crowded, whereas the other facilities remain empty, and there is no proper distribution, which was really originally visioned in the plans, also not happening. So I think it is time to organize these shortfalls. The intention is good. I think it's very good to have a comprehensive insurance to everyone, but I think it's time to correct it, probably to improve the premium a little more. I'm sure the department have a health has a very good vision, and I'm sure they will correct it soon. They have managed everything much better than before, as we know that how they have beautifully managed this pandemic, and officially they have corrected it and good control on this pandemic. So I'm sure the health department and the supervisory body, along with the insurance, will both insurance and the providers, we can come to a better conclusion, and it will be sooner than later. Once again, I thank you, MedTech, for this opportunity, and I thank Mr. Vikas for the nice coordination being done. Thank you.
Thank you, Dr. Kasim. So I think we have got the good sense of pain and then the overall healthcare system, and I could hear that system is good, built in with a lot of improvement areas and then dreams to make it a world's best healthcare. And obviously there are challenges which I could sense that of delayed payment or restriction on approvals or a close tight system which is creating some pain in the system to have a quality care. So now putting all these points, if I move ahead, and then Dr. Joseph, if I may ask you please, that what do you see the need of change? Like Dr. Kasim has said, the system has been built in properly, but somehow is not matching to the price at certain levels, right? So which means, is there a need of change in the system, either price or value? What do you see that the current offering in primary healthcare in the basic plan cover, do you see there is a need of change? Or what's your opinion on basic plan cover, that is it aligned to the quality care which provider can provide considering the constraint of the cost? Or do you see is a pressure on the provider as well as on the payer, since both are an integral part of the system, somehow both are or affected? Or do you see that patient is suffering because of all these, like Dr. Kasim has just mentioned, because of delayed approvals, restrictions, the quality of care is not managed as well as it could have been, just because the system is there but the price is not matching to the expectations? And the last, do you see, like it happens in India and many other countries, that basic plans is two control plan should cover only and only inpatient and emergency care, so that it's not overutilized, it's not taken for granted? Or will that help, or that's not something you believe? So if you can share your views on all these 4-5 points, that what do you see current as well as upcoming challenges, or you see that okay, this is what we as a leader can see and think of the current existing primary healthcare system.
Thank you for the opportunity given. I would like to mainly restrict my talk on the point is the current premium amount for the basic insurance policies, is it viable?
Got it.
While I'm not an expert, armed with years of research on the national data on the cost of medical care, I've been practicing medicine for the last 37 years in UAE. And in my humble opinion, the current premium rate are not viable at all. A lot of thought and research must have been done by the expert committees before fixing the premium limit of around 600 in Dubai or around 1,000 in Abu Dhabi. The competition forced the payer or TPAs to sell the policies for 300 to 450, out of which they have to pay the reinsurer. They got their own fixed costs. And ultimately, this leaves approximately 150 to 300 dirhams per person per year to cover the full medical cost of an individual. Our authorities were benevolent in that the basic policies cover almost everything, including chronic illnesses and vaccinations. I pay over 30,000 dirhams for my medical insurance, which will allow me to take only 7 physiotherapy sessions in the full 1 year, whereas the basic cover is much better than that. The authorities rightfully wanted our healthcare system to be world class. Today, my clinic got a nearly 100% Bayang score. The labs are EAC accredited. The radiology is FNR accredited. But to attain and then sustain these, a reasonable fund flow is needed. In 1995, that is 25 years back, Mr. Williams offered a year-round outpatient medical care for industrial workers at 350 to 500 dirhams. His contemporaries, including me, were skeptical. How can he do this? But he proved them wrong and successfully ran this plan for over a decade. The authorities appreciated his work and wanted to copy this plan. In 2007, after months of study, the country was about to implement the plan when the recession hit the world and the project was shelved. The plan was to give the money directly to the clinics without any role or any share to the payers and DPS. Those days, there weren't any stringent clinic standards to maintain or account for. Cheap medicines were available in bulk packing. The salaries of the doctors and staff was 1/4 of what they are today. In 2020, we are trying to service with less. I feel that today payers, and one of the main reasons are that low premium rates. That brings us to the question: what is the reason premium amount, and who? In my and only my opinion, the premium should be at least 1,200 a year, and the whole burden of this will go all on the employers, which may be difficult during this recession days. A better option will be for the premiums to remain or marginally increase, but patient pays on each visit a fixed fee directly to the clinic. So the clinics get some cash flow, not waiting for months or years to get their payment from the insurer. Say around 50 to 70 for a GP and 70 to 100 for a specialist. This will include consultation and all the usual investigations and procedures. Approvals need to be taken for any payments from an insurer, like expensive investigations, procedures, and hospitalization. The advantage is that the patient and the clinic who bears the bulk of the cost will try to prevent overutilization. If it is, the patient will decide not to go to the clinic if it's absolutely not required. There is no point in for the clinic to overutilize because his amount is capped. There should be a lower limit for medicines too, say 500. Now it is, I think it is 1,500. The insurance pays only for the pre-approved expensive investigations and procedures, medicines with a cap, and hospitalization. Any payer, TPA, or provider who undercuts should be penalized. So otherwise, as you said, this insurance should cover only hospitalization or emergencies. The normal OP should be cash-based and not covered. Every country that started universal insurance went through a lot of painful changes over decades until they reached the present stage. None of them think that they have found a perfect solution yet. Switzerland increased the premium 6 times within few years after starting the insurance. The change is inevitable. Let's hope it will come soon and save all the healthcare partners who is in crisis today. Thank you.
Thank you, Dr. Joseph, for the well-researched views and your touch base, from UAE to Swiss, from primary healthcare to basic plan. So it is, I could hear many valid views and points which everyone is, having on their own mind. Thanks for that. And I could see that you have raised a big question on the premium rates versus quality of care in the basic plan. I could hear that costs are gone up. This plan was built beautifully, but the cost has gone up to the roof. So you're not, provider is not able to manage the care in that particular cost. I could hear the need of the limit of the medications, capping on the services, plus the need of government, or that government has to enforce the laws, or government has to enforce the rule engine which they have set up, so that overall system will evolve to a better governed system of primary healthcare. And since we know primary healthcare is the system which should be matured enough to cater the needs of any country. So thanks for all the views or all the, topic which you have raised. I'm sure everybody will have some of the question in their mind. And now one of the point you raised, since it is linked to the payment cycle, and Dr. Kasim also touched base that area, I would like Dr. Ranjit to share his views and give some or shed some light on how it is impacting providers. Is it impacting the payment cycle? Is it impacting the overall care? And how do you see that providers are qualifying or benchmarking the payers the way we have seen in the recent past, in last few months of some of the instance of the TPAs? Do you see that there is a need that payer should pitch in, or TPA or insurance has to work hand in hand? And again, on the other side, do you see that payers has to play a bigger role with TPAs to make sure that the system, which is already very tight in terms of a price versus care, is ensured that okay, payment cycle is good enough, providers are giving the care at certain cost, and patients eventually are not suffered because of delayed payment, rejections, approvals, all those points which were raised by the other panelists. What's your views on this, Dr. Ranjit?
Good afternoon, everyone, and thank you for MedTech for giving me an opportunity to share the platform with the great veterans who are the pioneers in this field to discuss the challenges and solutions in primary care. We heard from seniors that how that transformation of the business from cash to insurance and challenges what they faced during their journey, and most of them covered what all the problems we are going through. So I would also like to share mine. I started Imara Healthcare in 2015 when our great leaders made insurance 100% mandatory. for all the residents staying in UAE. Yeah, which is a good initiative by UAE. Thinking that from a business background back in India, I also start in the healthcare industry. Like Dr. Hammond said, so it's a lucrative business. I entered up and started. Even I also faced challenges like empaneling with the insurance companies, where it's very difficult for me to empanel with insurance companies because there was plenty of competitors around. So I had to compromise on the tariff and I have to agree with the low tariff with a discounted rate. So which you like you asked me about the payment issues, which made me the cash flow shortage because of the delayed payment, and which was affecting my cash flow, and the operations was affected. This was the condition for most of the healthcare here at the present scenario because of the late payment or delayed payment. The entire providers have got affected doing this. So I feel so before coming to this webinar, I discussed with my team and I told them that we're going to talk about the challenges and the solutions. So my feedback, what I got from my team was that like more like what Dr. Joseph said, we have to increase the premium to 1,200 dirhams minimum to reduce the burden of the insurance companies and TPAs. And what we can do is a reasonable tariff revision in the low network policy, which will again sustain the business because if you increase the premium. And like Dr. Joseph said, that to cut down on the capitation model, most of the insurance company or TPAs accepting the capitation model, which again is a pain for the insurance companies to achieve or maintain the operations of the insurance companies. And the insurance issuing policies, like your LSB and NLSB model, the low salary band and the non-low salary band, I feel less than 4,000 falls in the low salary band, and more than 4,000 is non-low salary band. If insurance company strictly adhere to this issuing the policies, we can sustain this operation, and there will be no much burden on the insurance companies. I feel another thing is direct payment system. When for the primary care, patients can come directly get services and get treated in the primary care and get reimbursed from the insurance company. In such a way, the utilization of the patients has come down, and there will be a genuine usage of the members. And finally, what again the payment approval also, the lack of prior authorization monitor. While seeking, what is happening is, while seeking a pre-approval system approves by default. Based on the approval, the clinic gives the services with the and all the services and investigation, but rejected at the time of claim submission. If there is a proper system to monitor, we could avoid and can be collected directly from the patient. Yeah. And last but not least, we see patients visiting multiple clinic at the same time and overutilizing. What we can do is we can introduce a patient information exchange system, should be linked with all the providers, that will avoid patient visiting clinic multiple times, and it will reduce the burden on the insurance companies. I think most of the other problems has been addressed by our veteran leaders. If we follow this and stick on to this by above said points, and it is a cycle where insurance provider and the members and the insurance companies are linked. If each one of us genuinely stick on to the rules and do not overutilize, I think like what Dr. Ahmed says, the quality, affordable service can be given in healthcare, which will fulfill and prevail our great leaders' vision.
Got it. Thank you, Dr. Ranjit. Thanks for telling us the key points which you see, the impacting the payment cycle, and then some of the solution which you see can be worked out, either direct payment system or increase in tariff. And being a responsible provider, you touched upon that the utilization also has to be monitored, and that payment should be linked to the quality care, so that if you serve the patient with the care, then you get paid. If there is overutilization, obviously payer has all the rights to do whatever is needed, right? And the another thing which you have raised is, which I believe government is already working on this, is that patient information system is linked to all the facilities, which is normally available in all the Western countries, wherein irrespective of wherever you go, you have a database of a patient you can pull out or you can take it out. So, and that's the, you call it, which I've seen some research paper, is that's the main, you call it a, founding stone of a strong primary healthcare system, because that's where you control the cost, that's where you see the utilization, that's where you see the disease management, and then you work on separate parameters. So thanks for the valuable points. Now coming to the solutions, since we have discussed the current challenges, starting from Dr. Ahmed, Dr. Kasim, Dr. Ranjit, and Dr. Joseph. Now let's talk about some of the solutions, and some of them are already raised by Dr. Ranjit or informed by Dr. Ranjit, that how can we overcome these challenges? What are the solutions as a leader of this primary healthcare we see are required? What are the things we as a provider needs to do? What are the things we need government to help out? And what are the things we see should come from payers or insurance payers or quality PAs to have a balanced ecosystem which is win-win for everyone? And eventually patient is the centric point, wherein patient is getting served by all with one rule, and that rule is very simple, that you know serve the patient with quality of care. Now coming to the solution, and if I may ask Dr. Kasim, since we have touched upon premium, is not sufficient, care is suffering, what do you think, since government has implemented, do you see government has to play a strict role in having this two-tier approach on this mandatory plan, that okay, less than 4,000 this is the policy, above 4,000 this is the policy, same like it goes in Abu Dhabi? And I was sharing with, I think yesterday, with some of my friends, that I've seen one of my friend's father is paying 15,000 dirham for a basic plan. So it's not just 1,000 dirham. It's a system which is linked to disease. It's a system which is linked to age. It's a system which is linked to all the other parameters, which eventually decides what should be the premium, what should be the criteria, or what should be the network, and how the care can be given. So what do you see, Dr. Kasim? Do you see a major role of this, balance approach, two-tier approach? We can't hear you, Dr. Kasim. You're on mute.
Yeah, the intention of the government and the authorities are very clear, and there is no doubt the insurance system is very much needed. But I think some fine tuning, which I think I have a tremendous hope and a feeling that this can be corrected easily. One important suggestion Dr. Joseph is already putting, that is just to improve the premium. When Dubai is a city, an international city, high quality city, where the cost is very high. It cannot be compared with a developing country. The Dubai UAE has managed the pandemic much better than United States or many European countries, isn't it? So it's a very high quality city, and the healthcare standards are also very good, which cannot be that. This does not go together. We have to have a minimum cost involved. So I think when the premium internationally is something like 2,000, 3,000 an average, how can it be done with 500 or 600 a year? It is not possible. So I think one first step will be to improve the premium. At least we have a comparison what we are doing in Abu Dhabi. Even if to that level strictly we come, we will be very much better off than what we are today. Number one. Number two, the payment cycle. I think Dr. Joseph again suggested that if outpatients, even Dr. Ranjit said that, if outpatients can be on reimbursement, because inpatients is a huge amount where people cannot will not be able to do a reimbursement. But if you are doing it at the outpatient level, this will save a lot of things. And as you said also that there has to be a level, because a company, a construction company with say 10, 15,000 workers, how can they have such a huge policy? It is not at all affordable. Where those workers having a salary say 1,000 or 2,000, they should have an affordable insurance policy. Whereas people who have an income and people who are living in family, senior members of the community, how can they have this PCB now? And that is what is happening. So it should not be allowed. There must be strict parameter of how who is eligible for this PCB and who is not eligible. If you have this categorization done, I'm sure things will be much better. There is no point in blaming the insurance company or anybody or even the authorities. The authorities also wanted to improve things, and they are working very hard. But somebody has to put a solution where the providers are now being jammed actually. Providers are the people who give the services, who give the medicines, and they are not being paid on time because the system doesn't have the cash flow to pay them on time. So I think these are, if we change these things, I think it can be easily corrected, to do this well and to achieve the goals of these leaders.
Got it. Thanks, Dr. Kasim. And then taking your point, wherein that, yes, it has to be linked. Yes, there has to be a fair value to the premium. Now, considering all this, and then obviously linking the question of payment getting delayed, pressure on payment cycle or cash flow management. My question to you, Dr. Ahmed, do you think that decision, which we might have seen 2 days back, decision to merge the insurance authority with the central bank, will help the overall ecosystem of healthcare? What do you see that, the action which will come out so that it can help out the providers, payers, and the patients? You are on mute, Dr. Ahmed. Dr. Ahmed, you are on mute. I think it's all good, Doctor, now. Yeah, all good.
Okay. Is it the health insurance or general insurance linked with central bank?
I have heard that the insurance authority overall is
No,
merging
that
with
is
the central bank.
overall health insurance. That is nothing specific for health insurance. There won't be any change. This is general, this thing.
Got
So,
it.
see, the problem is inherent with a sudden change. We are changing from cash to insurance. That is inherent. We jumped into we were behind the insurance companies to empanel them, and we jumped to them. We are not aware of these dark areas which may come in future. They were also not aware. The authorities who with good intention implemented, they were also not aware of it. But so the problem is inherent. But we have to each step, we should, or they should correct it in the proper way. Personally, what I feel, the health insurance regulatory body should have a better control of the insurance companies and third-party brokers. They should have some, and they should see the either side of the problem, because there are four groups playing in this: the patient, the providers, the insurance company, and the authority. All will have to be watchful of what is happening, where the things are moving, because they are introducing a new system. So they all should watch, especially the authorities should watch where things are moving, and they should interfere whenever situation arises. That has not happened here, though it is part of the problem. So if the health insurance regulatory authority has got a definite control on all the parties, this problem should have come to this side. That's what I feel. And all of us know the present premium, as Dr. Kasim told, with normal case, the premium what they pay is sufficient only 2 or 3 visits. That will be sufficient only for 2 or 3 visits, outpatient visits. So how can we survive? So problem is strict regulations to control all parties concerned. And again, insurance companies, an unscrupulous use of facilities, either by patients or very few from provider group, not for all. And the blanket rejection and blacklisting of all providers by insurance companies. This should not be there. There should be a win-win situation for all, for the patient, for the insurance providers, and for the healthcare providers. All should be benefited in a proper way.
Got it. Thank you, Dr. Ahmed.
Okay.
So I agree with your point that there has to be a win-win situation. It's a very valid point. Now, my next question to Dr. Ranjit, since you are the youngest amongst the veteran leaders, maybe with 40 years of experience, what do you see that providers can help in primary care in terms of reduction of cost? Can providers help in terms of reducing the cost of primary care, which in turn will help to reduce the premium? And what do you see that technology platforms plays a value in this, and how technology platforms, be it telemedicine or automation or digitalization or data mining, can help in terms of a contribution to the primary healthcare? So basically it's about how do you see providers can help in terms of reducing the cost of the care, plus how do you see technology can play a role in this whole piece of healthcare? Dr. Ranjit, over to you.
Yeah, like I told you, in the solutions that there should be a platform which exchanges the patient data, which has been linked with all the providers. If you do that, what is happening is patient will not visit in other clinic multiple times, and the data has been shared. So overutilization can be cut down on this. Yeah. How patient can be genuinely treated by the providers? Yes, they can be treated by the providers. If there is authenticity and genuinity on that. There, what I see is most of them treat this insurance card as a credit card. They just blindly visit a couple of centers and they utilize this opportunity of the people all this while who have not gotten a card for a treatment. They consider this insurance card as a credit card and then utilize this. If we are doctors, stick on to it, our policies, and be genuine and treat the patient who's a needy. And another way where we can give a proper genuine treatment is if we make this insurance systems a direct payment system and reimbursement from the insurance company. Those who are eligible, who need, will pay and get treated and get claimed from the insurance companies. So after this way, we can genuinely give a treatment for the patients. And in our great leaders are introduced as a low premium network or PCP network for those people who are really in need. But I see most of the even the CEOs carrying the basic network and getting treated with the current insurance, like other doctors said. It is definitely not possible for the insurance provider or the insurance companies to take care the entire year with the premium whatever they pay. So the simple solution is to increase the premium from 1,000, from 600 to 1,200 minimum at least, and stick onto the policies and the patient exchange system provider so that we can avoid patient visiting the multiple clinics.
Got it. Thank you, Dr. Ranjit. Yeah, so I agree to your point, which you have raised, that it has to be a value, to both the sides of the.
Because it's a win-win situation for the providers, for the insurance company, and the members. If all three people are genuine, and it's a cycle. So we maintain a healthy relationship, so we can give a quality and affordable service for the members at an affordable cost.
Got it. Okay. And then since you have touched base that, okay, since there is a payment cycle, since it is linked to the payers, my next question related to this, and to put some stress on this topic, to Dr. Joseph. Dr. Joseph, what do you see is the payer provider relation the way it has to be? Is it happening now, or is that sandwiching the patients between both? And what I'm coming through is, if you see 20 years back, right? 20 years back, maybe there was no insurance or very little insurance. Then the moment came wherein insurance or payers needed the providers, so everyone was getting empaneled by just a one call or by a no name like you guys, since you are there from last many years or almost 3-4 decades. Then the phase came, let's say 3-4 years back, wherein as per some of the data shared publicly by government, that there are certain areas where there is an oversupply, there are certain areas where there is no supply or a less supply, right? So when that happens, which means, is there a requirement for a new provider by a payer? Is insurance company or a payer looking for a new facilities? Is there a need of new pharmacy in certain areas, which opens up all the questions that what is currently needed, right? So when that question happens, then obviously both parties, which is eventually the payer and the provider, which are the service provider, unlike the patient who is at the recipient end, what do you see that payer and provider relation also, there is a need of change currently in the current scenario. And like I just heard from one of my team member yesterday that, sir, why can't we have a client service manager? Why insurance company always have a network manager, right? And that was given by a quality guy. And I was thinking that yes, there has to be, like in retail service, there has to be after sales service, which eventually, one, you take a policy, broker comes in, insurance company place a order, corporate gets the policy, it starts. The real burn happens when it comes to the policy running. When policy is run, if it is not effective, then the whole pain starts, right? So that's why, I was just thinking yesterday that yes, there has to be some sort of a, client service management instead of a sales management or a network management, which eventually creates a need for payer and providers working cohesively, working in tangent closely, to monitor this whole overall primary healthcare system. So what do you see that there is a need of change in the relation of payer and provider the way it is currently? Dr. Joseph, to you.
Definitely. I think currently the relation between the provider and the payers or the TPS is really straight. Mainly, both of them cannot run the show with this premium. The TPA say there is overutilization by the provider. And I should admit that there is a few doctors or clinics who will be overutilizing. Many times there is a dispute whether this is an overutilization or not a overutilization. So many times, as you said, we take a approval before doing the test, and later on the rejections come. If the approval, if they think that it's not reasonable, they should be rejected then and there. Then we can collect the money from the patient and do the service, which is not happening. So definitely there is strain. Mainly it's because with this limited money, nobody is able to survive.
Got it. And how do you see, Dr. Kasim? I've just got one question from one of the viewers. How can delay in payment cycle be addressed? Which we heard so far that yes, there is a problem. Yes, there is a delay in the payment. Now viewer wants to hear about that as a leader or veteran leader. How can delay in payment can be addressed? If you can shed some light on this, a straight answer.
It's all the same question and answer. We have a very small cake, and everybody is taking the share, and there is nothing to back, for the insurance company. See, when an insurance premium just be about say 1,500 or 2,000, when we are selling for 600, and the question of overutilization comes because of that, because the insurance company itself is strange. The TPA cannot manage with this 600. And the patient utilization is very high. A patient with chronic infection, paying this 600, his one-time medication itself will come to 300, 400 dirhams. And this is approved by the insurance company and we give. But if this patient every month or every 2 months buy medicines like this, how come this will become viable? So it's not possible. That's the main thing. As to just to add to the point which Dr. Ranjit told about this reimbursement. If the primary care outpatient is in reimbursement, certainly the all the clerical job of the medical centers will go away. Which is we are giving huge overhead for approvals, submissions, follow-ups, reconciliation, payment follow-up. Huge this is going. So all these unwanted overheads can be avoided if it is reimbursement. Whereas inpatient, it's okay. It's okay. We could continue to have on direct billing. So this is one very good thing actually. And of course, the insurance companies, it will be much better if they. But I was told, just like there are a few, as Dr. Joseph mentioned, there are a few cases of maybe overutilization in some of the clinic or by some of doctors. We don't say we are 100% perfect, but majority of them are not, because we are taking approval. Only after the approval of the insurance company, we are giving anything. We are not even supposed to give even a small nebulization or a 20 dirham service without approval. But even after taking approval, after 6 months or 1 year, if they come and do an audit, it's very difficult for the provider to do that. We are supposed to uh, preserve the documents of 4 or 5 years, for the audit purpose. And these are not really practical at a primary level. So I think reimbursement will solve most of this problem. So I think most important thing is and also I would advise in between that there should be an interaction between the provider, the insurance company, and the health authority, so that we can create regulation. We have been never been called for any discussions until now, after 4 or 5 years of installation, to take part in a discussion where we can improve and our relations also can be improved, so that we can work together and win-win situation can be created. But that's not happening.
Got it. Valid point. Yeah, I agree that there has to be a.
I want to add on point.
Yeah,
See,
doctor.
at present, in work site injury cases, there is this direct payment is existing. That is running. That is nothing a new system they have to do it. At present, in work site injuries, these claims are done direct payment wise. So it is not a difficult task to implement it.
Got it. Okay, now since you have touched base this overall clinic mechanism and then the how the system is working, one more question I've got from one of the viewers, that why the consultation charges for the doctors in the primary healthcare are so low. And even I can feel, right, everyone can feel that one doctor sitting in primary healthcare charging 20 dirham, and you pay more to a barber shop eventually, right? Or for a burger.
Yeah.
So which obviously is a worrisome matter for, I believe, overall healthcare system. And this is not the the overall rule of the engine. This is exception. 20 versus 1,000 dirham or 1,200 dirham in some of the hospital, or even maybe 1,500 dirham in some of the hospitals, right? And now obviously we can imagine the need, the care of a GP versus the care of a surgeon. But I believe this is a very valid question, that when consultation charges are capped to that much level by insurance companies, and obviously this is killing the overall morale of the new doctors. And how do you pull new doctors, right? And considering in corona scenario or a COVID scenario, wherein I believe, which you have not touched base, which I'll ask maybe Dr. Kasim again, the manpower shortage, or that we are not able to get doctors or nurses specifically from India, and that's the country, I believe, India or Pakistan or Philippines, where you get most of the healthcare people coming from, specifically in the primary healthcare, being the cost driven healthcare. So what do you see, again, Dr. Kasim, back to you? How do you see being a doctor that consultation charge is of so low is impacting?
No, I think I would add to the questioner that the consultation is 20 or 30 dirham. But what actually the patient pays 5 dirham, because he pays 20% of the 20 dirham, which is 4 dirham. So actually we are getting only 4 dirham. The balance of the money we have to wait for months to get that money. So actually you can, this is again creating misuse. Misuse means if there have been a reimbursement and the patient has to pay from his pocket, at least for the time being, until they get from the insurance company, he will not go to a doctor unless it is really genuine. Now they have to pay only 4 dirham or 10 dirham maximum, even to see a specialist. So they are tempted to go or misuse the facility, and they will go to one doctor today here, and the next day they go to another doctor in another clinic. Again, because as we discussed earlier, the medical records are not being exchanged, and so it's difficult. It's difficult. So this is too low, too low a charge. See, a medical professional, apart from his salary, to maintain a medical professional in an establishment, we need to have a lot of overheads. And a lot of overheads. He has to have a professional license. He has to have a resident visa here. He has to have immigration, so many other things. And in spite of that, and then, they say that, you are seeing too many number. But even the number is less. I want to say an example. I was working in Saudi Arabia about 20 years before coming here, where when the insurance was introduced much before in UAE, actually the medical providers were enjoying, because there was once, first of all, the premium was better. Second thing, there were number of patients in the facilities increased. Here what happened is the number of facilities in many of the smaller centers got less, and patient migrated to either to multi-chain facilities, or where they get these close net things, or to the hospitals. So actually the number of patients came down. So this is there's a lot of issues going around. This is not being dealt with properly. If it is dealt with, it can be easily corrected.
Got it.
I feel,
Okay, so
sorry to interrupt you, I feel there's, like you rightly said, the morale of the doctors is going really bad because they spend the entire 10, 15 years to become a specialist or a general physician. And finally, you end up getting 10 dirhams to 20 dirhams, and like what doctor said, 5 dirhams actually for the clinic. It is really disturbing, and it is very difficult to maintain the specialist in a medical center. The cost was really, really high. So, to sum it up, the entire solution for this is to increase the premium, which will, save the money for operating the insurance and the provider. I feel, and the LSB model and NLSB sticking on the insurance policies should help us, I think, to run the show without any problem.
I
yeah,
don't think it is the morale of the doctors going down. It is heartbeat of ours. The clinic owners is going up.
Yeah,
When the salary, when
we being a doctor, we also affect that.
when the salary for an average doctor was 5 to 8,000 dirhams,
I
the
know.
consultation, GP consultation was 30 dirhams and specialist consultation was 50 dirhams. That is the last minimum. That is 20 years or 30 years back. Now we are paying the doctor 25 to 35,000 dirhams salary and all ancillary charges, and the rent has gone twice that was what was paying at that time. So the running the clinic or the healthcare provider or entrepreneurs, they are facing the problem.
got it. And this, since Dr. Ranjit, you have raised the topic of the overall morale of the employees or doctors, which ultimately in turn is the frontline warriors or frontline workers in a normal scenario. I've got one more question from one viewer saying, ultimately, all these what we are discussing, all these changes and decisions which affects the employees and frontline workers, including doctors in the primary healthcare setting, right, which we have discussed. What do you see as a leader, Dr. Ranjit? What strategy would help you as a leader in implementing or retaining these employees and improving the motivation levels? Since you might have seen, and obviously the recent past was the worst to manage the overall healthcare, workforce. One, because they were managing the emergency scenarios. Second, there was a scarcity of the resources. So what do you see, leader has to do in terms of retaining the employees and creating improved motivation levels?
See, basically, what I feel is how good you are maintaining your employees or understanding your employees. They are the strength and pillar of your organization. I definitely say that we also gone through a tough time where during the COVID seasons, the patients come down and the operational difficulties. What I did is I spoke to all my employees. I discussed my problems with them. They were understanding and they were ready to cooperate with me and by cutting down the salaries and then you know because they know very well know the entire globe is going through the economic recession. So I feel by proper communication with your staff, and if you feel that they are part of your group, definitely they'll support you and we can sustain.
Got it. Yeah, that's clear. Since employees is the asset, I believe, for any organization. That's what we believe, and I believe that's what everyone believes. So I think that's the way to keep it up and running. That employee has to have a, you call it a trust of the leadership or the owners of the clinics or pharmacies or the labs, so that at least they are running the show. Now another question which I've got from one of the gentlemen saying that with a lot of corporates having this severe financial issues, including the biggest one in the country, which you might have seen just few 1 week or 2 week back. The question is that when a lot of corporates are having these severe financial issues in the current scenario, plus they are not renewing the insurance, though it's a mandatory insurance, how do you see is impacting the healthcare services to the labor class, which is left without salaries, right? Left without cash, left without insurance. And obviously they don't have option to go back to the country and then suddenly decide, oh yeah, now it's done. Tomorrow I'm going back to the country, right? And since we are all working in the primary healthcare, specifically for the value healthcare, Dr. Kasim, what do you see? Is it a, or is this a literally a big bomb sitting for the corporates having severe financial issues considering COVID scenarios? And then we have seen in many examples, and specifically to the labor class, or you call it a unprivileged community, left without money, left without salary, left without insurance. What do you see a solution to this?
Well, we are always kind, and I'm sure most of these doctors working are from India or from Asian countries, and we are definitely there to help them. And we are ready. We can only say that we are ready for anyway. This is a special scenario. A pandemic is a situation where there is a crisis. When a crisis comes, we don't talk about normal things. We are definitely very and very sympathetic to these patients. We can definitely work out a plan, which will really help them. We have our doctors, organizations, and also the medical centers ready to go there and help these camps. We are do. This is beyond the insurance or beyond the business perspective we are discussing. Definitely, it is possible. But I just quote a friend of mine. He's an HR manager of a big multinational company. He says, according to him, these PCPs are now better than what they used to manage before economically. For the company, by say, if it's a company with 5,000 employees, if they take a 400 or 500 dirham policy, I think that works out to be cheaper than what they used to manage alone without insurance. So I think as far as low network insurance is concerned, I think for workers, it's a very good plan even now. They get a cover, they can see a doctor completely, and they give a very little deductible. And this is a very good thing. And that is what the intention of the government was, actually, to get a very good cover for this low income group. That was actually being misused by other people. So I would say this is one strategy where the local network will be useful at this time or at any time. And of course, to the question of this one, we are always ready even to give a free service to these laborers at any time.
Since Dr. Kasim, you have touched base that, and you're kind enough to extend the services to the needy or the labor class people or wherever it is needed. Now another question which is coming on my screen from another viewer is asking that how do you see reimbursement coming as a solution? And this is to you, Dr. Joseph, that since patient has to pay, let's say 20%, majorly in majority of the cases, a patient has to pay 20%. Do you see there has to be a change in the model? Do you see, can it be a bundled OP services like you might have heard DRG system for IPD services, say consultation with injection, this is how it is. So at least you get rid of your rejections, which means you get rid of your delayed payment cycles, which means the clinical protocol is common for all the payers, right? So basically the straight up question is that do you see OP services can be bundled like a DRG system for IPD, which is ongoing in Abu Dhabi and going to implement in Dubai? Dr. Joseph, over to you.
Yes, of course. The, the, the only way to solve this problem is that the clinic should get an upfront payment. Then only the clinic can run. Clinic need not wait for years together sometimes. Two of the major payers has not paid me for last 2 years. And I got no way to go against them. 2 or 3 TPAs has run up. I got no way to go against them. They already left the country. Even if you put a case, nothing is going to happen. So ultimately, if the patient is paying some big amount from his pocket, big amount for his pocket, then the first overutilizations will end. So, but as I suggested in my talk, even 50 to 70 dirhams, which includes almost everything, only the costly ones, which is used only when on rare occasions, need to go for insurance approval and followed by their payment. I think that's the only way out, I think, for this sort of thing.
Can I add a point? As Mr. Vikas told, a bundle, is also possible, right? We fix a consultation, investigation, and medication together. We fix an amount. Let us fix by the insurance company or by the health authority, and I think even that will be much better than the present system going on where there is detection. Joseph, yeah.
See, I agree up to the procedures and investigation levels, not medicines.
Okay.
Because it's very difficult to control the cost of medicines. There was an insurance company who came and told me that you do the whole service, including medicines, for 70 dirhams. I don't know how is it possible. A chronic medication, as you told, actually will cost, is written for 3 months. And that 3 months may cost around at least 1,200 to 1,600 dirhams. Where we are supposed to do their expectation will be to manage for 70 dirhams, including medications. Is it viable? And if you are not able to do for 70 dirhams, after 1.5 years, they'll come for an audit and you repay all the balance amount. It's usually 100 rupees, 40 rupees paid back. So yeah, it is a very risky thing to take medicines also. Mr. William, in 25 years back, used to give medicines also through his pharmacies. Those days, cheap bulk medicines were available. We get 1,000 pack and we can dispense it loose. Now, if you want a cheap antibiotic, you have to pay about 30, 35 dirhams, nothing less than that. And how can you afford this? It's mainly the chronic illnesses which will cause a big problem.
Got it. I think, doctor, we'll have to send this recording straight away to payers first. So they will love this. Okay, I think since we are almost near to our closing time, the last question I'll take, which is for Dr. Ranjit. Since you were saying that there is a, good tracking system for medicine? And that's what viewer is asking. That agree there is a system for mechanism for the pharmacy issue, since it is PBM pre-approved, and then you get paid majorly, right? Almost 100% you get paid for the pharmacy. The question is that, is this tracking available at consultation stage also? Which I believe the question which we have answered is the patient, centric system. So if you can, share final words on this.
I feel if you could bring this system technology in the present healthcare market, we can stop this overutilization. And I heard through my team, they're saying soon they're going to bring this system where they're going to install the software, which will be linking the database of all the providers so that they can avoid this. Yeah. I feel they're going to bring the system. I'm not very sure. Presently, it is not available.
Got it. Got it. Okay. And then the last question, which I think is my favorite question also, that do you see need of clinics to come together and ask for a better premium of insurance as a one force, and then asking for the faster approvals, and it's like all providers come on a one platform, agree on certain rates? Or do you see, no, there will be a cat fight on that, it should be the way it is now? And maybe Dr. Hammer, to you are smiling on this question. I would love to have your views on this.
Yeah, basically our idea of this participation in this also to have such a situation arise some way, somehow. Earlier the better. Earlier we have such a situation, the better for the group, for the providers. No doubt about it.
Got it. I think, yes, there is a need of consolidation, and that's what we have seen in the...
Always unity is the strength,
Always, doctor. It's all blessing of yours and others. I agree. That's why I think we have seen consolidation in payer space, in TPA space, in provider space, maybe to, fight together. Yeah, I agree. And then before handing over to Sonia,
let me put a small point that there is also, see, these insurance premium, particularly low cost premiums, are sold to the public, particularly this, public with, low income group, under a very false propaganda that, this, you take this insurance, every part of your health is covered, So they come with a feeling that everything is covered. But actually there are a lot of hidden conditions in this insurance, which the poor patients doesn't know. So there is between the expectation of the patient and what actually he is eligible with this insurance, there is a huge gap in that. This is also producing a lot of confusion with us. And also, as Dr. Ranjit said about the technology, see, now we have about, I think we have about 50 or 60 insurance companies. And the forms they are using is at least 20, 25 years old. They should standardize these forms so that, the clerking part is much better. Now we have many insurance companies, they have many different protocols, of this. They should standardize this. This will make our work much more easier. And it's time, they already removed most of them with these hard copies. But I think still they are insisting to preserve the hard copies, which is also again technology induced now. We are in Dubai, and in a place like Dubai, still to where even government offices are using paperless. We are still using these papers, and they are demanding to keep these papers for 5 years. This is very, very difficult. So I think we should modernize and make the people know what exactly it is. In their, just like when you buy mutual fund, they say read the small letters. So when you take a policy, I think the people should be really educated what they are eligible for it, because this PCP cannot see a specialist directly. So these things they don't know. They don't know that they have got a limit of medications. They don't know. So they come and demand. So poor patients, they are into trouble, and we, the providers, are jammed in between. So this is a huge scenario that also should be made clear. Actually, I think all these problems can be correctable very easily if there is a dialogue between, and if probably the premium is somewhat a little raised. I think all these can be corrected, and we can all have a win-win situation.
Yeah, Yeah, doctor. I think adding to your point, just my 2 days experience in I went to medical. This is amazing, and I think it gave me a good start today. I went for a medical in uh, DHA facility. I was amazed to see robots walking there.
Yes.
I went inside, doors getting closed automatically. You
Yes.
know that even the dustbin even is automatic. You
That's
sit in, there is a wallpaper coming in. You come out, there is a robot standing. Now obviously that's not only for primary healthcare, but I can see the thought process of leaders of this country.
that's
You go in, it was like, you step in, you sit on a chair, the table itself has got a equipped tablets asking for coffee, tea. I was like, this is I've not never seen in my life. It's like a medical facility of a DHA. Anyone, if he'll visit, he'll be amazed to see. So I agree that I think some sort of innovation also is required. And to sum up this whole webinar, I believe, with all your experience, everyone on the panel, we have discussed in length all the I believe pain areas, challenges, and nevertheless the solution required. And the need of our, which I could listen from everyone, is that we have to come up together. Premium has to go higher, payment cycle has to be better, and provider and payer has to work in hand to provide the quality care. And I believe, as Dr. Kasim said, nothing is impossible. It is a amazing system, but as every system has to improve day by day, I think that's the need currently. And I'm sure with all the providers, payer support of government and DHA and Abu Dhabi, will make it better and better sooner for all of us. Thank you, everyone. Thanks for your time, and I'll hand over to Sonia. If Sonia, you can wrap this up.
Thank you, Mr. Vikas.
Thank you so much, Mr. Vikram. And yes, thank you, gentlemen, for today's wonderful presentation. I'm sure attendees of today's webinar will be taking some useful insights from today's presentation. I believe all of you deserve a round of applause. So, can we have a round of applause, please, gentlemen?
Yeah, for yourself, it's easy.
I'm sure our viewers are doing it as well. So thank you once again to our esteemed moderator, Mr. Vikas Katoch, and our panelists, starting with Dr. T. Ahmed, founder and chairman of Al Noor Polyclinics, Dr. C.I. Joseph, pediatrician and managing director of Jupiter Healthcare Group, Dr. Mohammed Qasim Paliatarite, chairman and pediatrician Al Shifa Group, and Dr. Ranjit Kumar Vijayan, CEO and managing director, Imara Healthcare, for such a wonderful discussion. And at the end, to all our guests who has attended this session and added yet another feather in our MedTech webinar success story. Stay safe, everyone, and looking forward to seeing you in our next edition, which we will be announcing very soon. Thank you, everyone, and have a good day. Take
Thank
care.
you, everyone.
Bye.
Thank you for your time. Thank you. Bye bye.
Bye bye.